As we were saying, we have a lot of physiology index here nowadays. But the one that I want to present to you today is an index that we don't need wires. And also we need only one projection to get the result of a physiology index. And it's also important that in this index, MIFR, we can access epicardial circulation, but also the microcirculation index. And also we can do it real time in the cath lab. So it's simply to connect the notebook, the cath lab machine, and we get the result online, so real time. So it's going to speed the process of getting physiology indexes without the need of coronary instrumentation. So we don't need wires to get the result. That's what I want to discuss with you today. So when we talk about physiology, the first question is why? So the main reason to use physiology is to decide when to perform PCI and when to do not perform PCI. The point is that when we perform PCI based on our visual estimation, we make a lot of mistakes. And the reason for that is that when we do visual estimation, we use percentage stenosis. And when we use percentage stenosis, so for instance, in moderate stenosis, like between 50 and 70%, it's like the flip of the coin. So we make a lot of mistakes when we do decisions based on our visual estimation. So it's really important to have a more accurate assessment of coronary physiology and then make the decision on when to do and not do the PCI. Another important concept that we have is that stable coronary artery disease is a benign condition. But, I mean, and this is based because of ischemia trial and also courage trial. But there are some situations that stable coronary artery disease is not really benign. In the courage trial, in the ischemia trial, the decision on when to perform revascularization or not was done in non-invasive tests. The point is that when we do invasive vessel-specific coronary assessment, it's completely different of when we do non-invasive tests. And this has been shown in the FAME2 trial. You are familiar with this study. And the main conclusion in the FAME2 study is when we have a positive FFR and we don't do PCI in this patient, we increase the chance of major event after 5 years in 64%. This is combined hard endpoints, death, MI, and urgent revascularization. On the other hand, also, if we check about myocardial infarction, the increase, if we keep this patient under medical treatment only, and the patient has positive FFR, the chance of a myocardial infarction increasing 44%. So a major risk if we don't treat this patient invasively. So the FFR, it's important to make the decision in when to perform and when do not perform a PCI. The how, you are all familiar with the FFR. I mean, FFR, we check, we do a correlation between the pressure in aorta and distal to the lesion. Under hyperemic condition, most of the time we use adenosine. And more recently, we have new indices without hyperemic condition. So we can do under baseline condition assessing most of the times diastolic pressures. And these methods are all well correlated and have good accuracy against FFR without any side effects of adenosine, papaverine, and the drugs that we need to induce hyperemic stimulus. But also, nowadays, it's more known that coronary circulation is not only epicardial vessels. So the coronaries that we see in the angiography represents only 5% of coronary circulation. And nowadays, it's also possible to assess the resistance arteries. And about 20% of the patients with chest pain, these patients have increased microvascular dysfunction. And this can be accessed in the cath lab using the microvascular resistant index. So this index is obtained using a wire. We can do in the cath lab using the wire. We assess the distal pressure and the time of transit of saline distal to the vessel. So we do that with a Doppler wire. So we put the wire in the distal part of the vessel. We inject 3 cc of saline, and we measure the time between the start and the stop of the saline infusion, and we check the pressure in the vessel, and then we can assess the microcirculation. In Brazil, I don't know the reality here in Colombia, but in Brazil we don't have this wire so far. But nowadays, we can do with the MIFR, we can access epicardial vessels, but also microcirculation using an angiographic tool powered by artificial intelligence. So what MIFR does, it uses quantitative angiography and fluid dynamics theory to reconstruct the vessel pressure and vessel flow. And the big difference and the big advance in terms of MIFR compared with the other index that we can use only with 2D. So what we do a conventional angiography. We do 2D or 3D reconstruction because MIFR also, if you want, you can also do 3D reconstruction, but saves a lot of time if you do with the 2D assessment. And then the software do a modified frame count, and then you have physiological assessment of this coronary vessel. Now, I want to show to you how the flow chart is. So we do a conventional angiography. The software measures automatically the flow velocity. It detects with artificial intelligence the vessel contours. Also, automatically, it detects every side branches in this vessel. And then we have the full reconstruction of the vessel. So the information we get is, of course, the vessel MIFR. So in this example, 0.69. So this value we use as we use with FFR. Lower than 0.8, we should treat. Higher than 0.8, we should not treat, as the same index the same reference values that we use for FFR. We can also have the 3D reconstruction of the vessel, information on stent length, so diameter, length, and also we can simulate, if we treat this lesion here, what would be the residual MIFR, and the goal is to have a MIFR higher than 0.92. So we can simulate what's going to be the final result of the PCI using this tool. Additionally, this software also shows to us the pressure pullback, so we can see where the pressure goes down. We can also access diffuse disease, and also the change in artery diameter. We have nowadays more than 700 publications on this index. So it's a well-validated tool that I want to share with you some novelty. So the first big validation study was the FAVOR2, in which they demonstrate a good correlation with the invasive FFR. They also run a meta-analysis, including FAVOR2, and the comparison between QFR, MIFR, and FFR, they use both. The mean difference was less than 0.01. They also have validated the one projection, MIFR, also with a very good correlation with invasive FFR, with an area under the curve of 0.97. And the big study on clinical outcomes was FAVOR3. So almost 4,000 patients randomized in this trial. In one arm, the MIFR/QFR were used to make the decision to treat or not to treat the patient. And the other half of the patient, the decision was made based only on the angiography. And what they demonstrate was that if you make your decision using this angiography index, the reduction in events is 35%. And this result is sustained after 2 years follow-up, 34% reduction in events, if you make your decision based only in the angiography. Another advantage of MUFR, you can check the resistant arteries as well. So when we do the MUFR, we can also obtain the microvascular resistance. Here in this patient, you see the microvascular resistance is 251. What they have demonstrated, validated against the wire for microvascular resistance as well. And also, again, good performance. The area under the curve is 0.94. So a very good correlation with the wire for assessment of microvascular resistance as well. And for these microvascular resistance, compared to the wire, the reference value is 250. So when we use the wire, the reference value is 25. When we use MUFR, the reference value is 250. So it's also well validated for microvascular resistance and to identify patients with INOCA and MINOCA. Finally, I have here 2 cases that I want to share with you from my clinical practice. And also, I'd like to have your opinion on what you do in these cases. So the first case is a male, 62 years old, with hypertension and high cholesterol, with angina, despite medical treatment, normal ejection fraction, no abnormalities in the ECG. If we look to the angiography, we see a very small right coronary artery, a non-dominant coronary artery, right coronary artery, with a severe disease, but small right. If we look to the left, we see intermediate lesion, a moderate lesion. Oh, sorry. A moderate lesion in the LAD, mid-LAD, a single diagonal, so this patient has almost only one diagonal. It's a long vessel with severe disease proximal as well, and a distal disease in this dominant circ. So we have this moderate lesion in the LAD, bifurcation with a diagonal, that long diagonal that I mentioned, and non-dominant lesion, non-dominant right, and this distal lesion in the circ. So now I'd like to have a little bit of your opinion here in this case. So what you do in this case? Number one, who would recommend CABG for these patients? Please raise your hands. Who would recommend CABG? So number two, who would recommend PCI? Only the right, the circ, and the diagonal. Number two. Okay. Number three, PCI, only the circ and diagonal. Who would do number three? Okay. Yeah, we have some number three, so the decision would be based on severe disease of the angiography, okay? And number four, who would perform PCI of the LAD as well? So LAD, diagonal, and circ. Okay. So most people will do PCI, number three, PCI of the circ and diagonal. I think it's a fair decision because 2 severe lesions in diagonal in the circ as well. So I think it's a fair decision. However, we decide to do a physiologic assessment of the LAD. And if we look, we have here a MUFR of 0.75. So the threshold is 0.8. So now we have a true bifurcation lesion. Not true because the osteodiagonal is not really disease, but we have disease in the diagonal and a 0.75 MIFR in the LAD. So I will ask you again this question. Are you happy with the MIFR, or do you want to know also FFR of this patient? Who want to know also the FFR? Or you change your opinion? So number one, who would perform CABG in this patient? Severe LAD by physiology, CABG, okay, we have one CABG. I think it's fair. Disease, trivessel disease, okay, yeah. Who would perform PCI of the LAD diagonal and circ? And also, we have the option of number 5, who would perform FFR. FFR, okay, FFR. So I work with this angiography index for almost 10 years now. I started during my PhD in the Netherlands, but when I had this case, it was my initial experience with one projection of MIFR, and also I wanted to check the FFR. I was learning with the tool. So this is the FFR of this patient. So it's also positive. So the decision we made was to treat the bifurcation, LAD and diagonal. Of course, we treat also the circ. The right we didn't treat because it was a non-dominant right. And so we treated based, guided by OCT. I want to show you how the angiography underestimated the disease in this patient. I will put in the MLA. So I will ask you sorry because it's really a little bit difficult to put. So I'll put the cursor in the MLA of this LAD. Well, I just want to try to show you that the MLA in this LAD. Please take a look when this cursor reaches this part of the LAD, and you see that the MLA is 1 square millimeters. You see, coming down, 1.5 square millimeters. So it's really severe disease in the LAD that was underestimated by the angiography only. So we decided to do OCT-guided PCI. It's interesting here as well, because when I was choosing the normal to normal region to implant my stent by OCT, look what was the suggestion by the MIFR software. So it's nice because it's very similar, the region that MIFR software suggests me to implant the stent, and the region we have in OCT as well. So it was a nice case to demonstrate the combination of two methods. So we treated both. So just nothing special in this in this bifurcation treatment. This is the final result. So we got the minimum expansion was at this point 87%. So a good angiographic and also good OCT result. Now we have only 3 more minutes. I want to share another case with you. It's an old gentleman with severe aortic stenosis and diabetes, with aortic stenosis with an area of 0.8 square millimeters. So before the TAVI procedure, we decided to do an angiography of this patient. So you see severe calcification in the circ, severe calcification in the LAD. So again, I like to reinforce the calcification we have in the LAD. A moderate lesion here in the LAD at this point, mid-LAD. Severe calcification. The right, nothing special in this right coronary artery. So this is the lesion that is somewhat, ambiguous. I'm not sure if it's severe or not severe, and the patient has to do a TAVI. But if we decide to do a PCI here, maybe we need to modify this plaque, maybe rotablator or cutting in a patient that has severe aortic stenosis. But also, if this lesion is severe, if we do TAVI, we have to do pacing in this patient. We may induce ischemia. So what would you do in this case? Surgery, TAVI plus LAD PCI, or TAVI. So number one, who would do surgery in this case? Number two, who would do TAVI plus LAD PCI? Okay, fair. Yeah, I think this lesion is really, yeah, in this left panel, for instance, doesn't look good, huh? And who would do only TAVI? Number three. Okay. The thing that I want to show now, the people that decide based on their geography, doing PCI or not doing PCI, they may be both right, because we simply don't know. When we make our decision based only in the geography, we simply don't know. It's like the flip of the coin. So you guys both can be right. That's the main point that I want to show here. And in this case, we did MIFAR.
Doctor Campos, un minuto más, por favor.
Okay. So we did MIFAR. The result was 0.95. So I have a few more seconds only. Also, it's an important point here. You see the macrovascular resistance pretty high. It's a common finding in aortic stenosis patients. We have a straightforward assessment of the cardiovascles, but the microcirculation as well. So you see the 309 macrovascular resistance. We have also invasive with a wire assessment of this patient, also a good result. So both results are good. So we decided to do the TAVI, and the patient went well without any problem during the procedure. So my final slide, my final conclusion is MIFAR is a well-validated tool that allows us to evaluate globally, the coronary physiology globally, epicardiovascular, but also microvascular resistance as well. Thank you very much for your attention.